This week on the BackTable podcast.
We found that these biologics are really safe. They're not immunosuppressive. They're not making patients sick. We're not seeing any big safety concerns. I mean, in some of these, we have indications all the way down to infants. So I think that our comfort with these biologics has expanded over the last few years. And I think seeing it used in real world data is super helpful. And so, yeah, I mean, I don't think of it end of line biologic. I mean, if a patient's coming into me and they're miserable, we are starting, like, it's first line in many, many ways for me. Get them relief, and it doesn't always have to be a surgical outcome if that's not the desire or the goal or the indication. And if they have like asthma and they have nasal polyps, I will sometimes put them on Dupi first and see how they do before they even have sinus surgery.
We have an amazing guest who's going to talk to us about a very interesting topic. We have Dr. Reena Mehta. She's an allergist practicing at Uptown Allergy and Asthma in New Orleans, Louisiana. And she is here today to talk to us about the role of biologics for chronic rhinosinusitis with nasal polyps and how she uses them in her practice. You may have heard Reena's episode 50, Building a Solo Practice, and she's back. It's been a little bit, but we're so excited to have you. How are you, Reena?
Good morning. Thank you so much for having me.
For anybody who maybe didn't get to listen to episode 50, and now it's been a couple of years, can you tell our audience a little bit about yourself, your practice, and some of the growth it's had since you've been on the podcast?
Absolutely. So I started my own private practice in New Orleans, Louisiana, February of 2019. Prior to that, I was in private practice, and prior to that, I was a group practice, I should say. And then prior to that, I was in academic. So I kind of had several jobs, moved to Louisiana, started my practice, my solo practice in 2019. And from the last podcast that we did together, at that point, I was, just a couple years in and renting space and solo, doing my own thing. And then since then, have bought a building, moved into a new space, hired an extender. I have a nurse practitioner now, and now a staff of 10 employees. So it's come a long way, and we're busy, which I love. And it's been great.
So today we're talking about chronic rhinosinusitis with nasal polyps, and particularly how biologics come into the treatment of those. How do patients with nasal polyps land in your office? Do they know they have them, or you're seeing them and it's like, oh, you have polyps?
Both, but probably the most common presentation is a referral from our ENT friends. As you know, a lot of times these patients will come post-sinus surgery, and they're trying to prevent recurrence of nasal polyps because we all know that 50% of the time nasal polyps grow back. So a lot of times it is that patient who has seen ENT, who's plus minus sinus surgery, who is coming to potentially start biologic therapy to prevent recurrence of nasal polyps. However, there are definitely times where I look in someone's sinuses, or in their nose, they think that they just have allergies, and you see a big old gunky nasal polyp. And then there is that collaboration of, okay, where do biologics play a role? Often they do. Do I send them to ENT if they've never had sinus surgery? So that's always the kind of back and forth.
Do a lot of these patients who either in your practice overall, whether they're referred to you or you found the polyps in their nose on your own exam, what % of them have associated like asthma and or allergies with it?
I mean, for asthma, 60%. And so, there is these atopic comorbidities that exist. Many of them, I shouldn't say all of them, many of them have allergic rhinitis, many of them have atopic derm. And so, as an allergist immunologist, we have the benefit of seeing all of the atopic conditions, which is really nice because you can focus on not just their nasal polyps, but you can also treat their asthma, their atopic derm, and often, that's where biologics come into play because you're trying to treat many of these comorbidities. So I would say about 60% of the time they have asthma and other things like that.
And you mentioned the patients who are newly diagnosed with nasal polyps and the discussion, I guess, on whether or not they need to see an ENT or not. And I've talked to some allergists who I think now that there are some biologics that can kind of melt away polyps are treating more polyps. What are your thoughts on that? Like, is it a conversation with the patient, or does everybody have to go to ENT or have to get a scan?
Great question. And I think this is where the discussions of patient preference really happens, So I definitely have patients who are, especially your elderly, they're 75 years old and do not want to have a sinus surgery, but they are miserable. They cannot smell, they cannot taste. It's been going on for 30 plus years. These are conversations I have with patients. So I definitely have patients who say, I do not want to have sinus surgery. What are my other options? And then you have, your 25-year-old who's otherwise healthy, who has these symptoms, but otherwise, is feeling fine. That might be a patient where I say, okay, well, why don't you visit with ENT? But often polyps do come back. And so that is where we can talk about options as a way to prevent having multiple sinus surgeries.
And for those patients that haven't had much workup, they're in your clinic, you're like, oh, I think you're starting to get polyps. What's part of your workup and management? Like how often, what is part of your lab workup in terms of imaging? Are you getting imaging? And if so, for what indications?
So usually, with these patients with chronic sinusitis, I present to them, there are three reasons why that happens. Number one is uncontrolled allergic rhinitis. And so we do a workup for that, usually skin testing, better understanding triggers, and plus minus allergen immunotherapy. So desensitization for their allergies. Number two, anatomy. So that's where ENT comes into place. Obviously, if there's obvious polyps, sometimes, there aren't polyps or I can't see them. I can only visualize so far. I don't scope in my practice. So, I'm suspicious of polyps, but I can't see them. I often will send them to ENT for imaging/scope. So I don't usually order the imaging myself because I know that if I'm going to send them to ENT, they're going to want to do it their own way. And they like to look at it and see the images themselves. And then the third reason we talk about is immunodeficiency. So obviously I'm an allergist, but I'm also an immunologist. And so patients with recurrent chronic sinusitis, that's often something that I think about is could they have an underlying immunodeficiency? Are they hypogam? Do they have low IgG levels? Do they have specific antibody deficiency? And sometimes they do. It coexists. You can have patients with chronic rhinosinusitis with nasal polyps and they're immunodeficient. So I have some of these patients on biologics plus IgG infusions. So that's kind of my thought process is allergies, anatomy, and immunodeficiency is kind of how I do that.
And so in ENT, if I see a patient with nasal polyps and let's say we've done a scan and we know that there's not anything sinister like behind the polyps, right? We know it's not like a tumor or anything else. It's just maybe run-of-the-mill polyps. I will typically start with nasal steroid rinses just to see if getting some steroid locally in there will shrink some things down. I mean, obviously if it's growing out of their nose, not. But let's say it's just starting to be like some, polypoid edema, early polyps. How do you think about local steroid delivery, and is that part of your algorithm too?
Yeah, so now then we're talking about treatment management options. Definitely. I mean, I definitely do sinus rinses with budesonide/intranasal corticosteroids, Xhance, things like that. But I mean, at the end of the day, it depends the extent of the nasal polyps, to your point. Like if it's mild and some polypoid and there's a chance that the delivery of the intranasal corticosteroid is going to get to that area, sure, okay, I think it's worth a try. I think also if they're younger, like I have like a 14-year-old who's got some polyps, maybe we try that first, more of a conservative approach. But generally speaking, if it's extensive nasal polyps, they're going to need to do something else. And I find that those that come in that they're like, I cannot smell, they're miserable, I cannot taste. I mean, their polyps are usually pretty extensive.
Is there a role for oral steroids in your practice? Like, do you use that often or?
Definitely not often. Sometimes, acutely to get them through a flare. A lot of times if they come in and they're completely infected and you can see the polyps and, I'll do it as a way to sort of get them some relief, but it's definitely not something I do often or want to do long-term, as we all know the side effects from something like that. So, I might say to them like, hey, I know you're miserable. We'll do this one time just to get you relief, but then we really need to talk about a long-term plan. That might be the situation where I piggyback it with the biologic. And then I say, okay, we're going to get you feeling better, but then we need to do something to prevent your polyps will shrink with the steroids, but then we need to do something to prevent the regrowth.
What's your go-to steroid regimen? Prednisone?
Yeah, I'll usually do prednisone taper, start at 40 and then taper it down over a period of 10 days or so.
And if their response to that, does that tell you anything? If they're like, oh yeah, I feel great. I got 4 or 5 months of relief and was feeling good and then now it's back.
Yeah, for sure. That tells me that it's probably a Th2-driven nasal polyposis. And so that certainly makes me think about where the role of biologics fits in. Plus minus sinus surgery,
If patients are coming back and saying like, hey, can we just do that again? can I just do that steroid thing again? Because it got me.
It's like twice a year.
Can I just?
Yeah, I know.
It's twice a year.
What are your thoughts on that?
I mean, that's
Where
always
do you
trying
draw
to fight
the line.
Yeah, I mean, that's always trying to fight the good fight, right? This is not a long-term plan. I mean, it depends on the patient, depends on compliance, it depends on how motivated they are to deal with it. But, if it's like twice a year, I may do it. If it's 4 times a year, I will not do it. Or, I'll encourage them to deal with it on a long-term basis. It came back once, it's going to keep coming back. The patients who tend to have extensive polyposis, I mean, those are the ones who their symptoms come back at so you can't keep doing this for the rest of your life.
And so when you are thinking biologics, let's say it's the 35-year-old patient, maybe they have a history of allergies, some asthma that's overall well controlled, but we have nasal polyps. At this point, let's say you've sent them to ENT, they've decided to do sinus surgery, and they're back in your office. And let's say it's been 2-3 months, and we're starting to see those little grade 2 grapes coming back in, so the symptoms aren't maybe horrendous, or maybe they are starting to have more nasal obstruction and some changes in their smells. At what point do you start thinking of adding biologics? And when you do start... Right then. And when you do, now we have a little bit more of a menu.
Yeah.
Tell us how you think about it, what your go-to is maybe. Is it always dupilumab? Or have they already, for their asthma, if they've already been on something else, do you switch it? How does that thought process work for you?
Great question. So, often I'll tell them after sinus surgery, why don't you come back and see me within 1 to 3 months, sometime in that time frame to see how you're doing. Because a lot of times now, patients have learned about these biologics. And my ENT colleagues will say, I will do your sinus surgery, but then you need to go to your allergist to talk about biologic therapy to prevent recurrence. So they kind of already know that. We've already discussed it before. And so when they come back to me, the question becomes if none of the polyps are back, they feel great, they're trucking along, then it's a discussion. We say, we can wait to see if the polyps come back, or if you want to prevent recurrence, because we know this has happened before, you've had 2 sinus surgeries at this point, let's kind of nip it before it becomes a bigger problem. We talk about biologics. If it's already starting to come back, oh yeah, we're starting it this day, because they're miserable, and why go through that again? So if they're starting to have any sense of congestion, it's starting to come back, they're starting to lose their sense of smell, I talk about biologics, let's get this going ASAP. And then in terms of biologic use, I mean, as you probably know, there are a few that are approved for nasal polyps. So we have omalizumab, which is Xolair, which is anti-IgE, your allergy antibody. We have mepolizumab, which is Nucala, and which is an IL-5 inhibitor. And then we have dupilumab, we call it Dupi, which is our IL-4, IL-13 receptor antagonist. So typically speaking, at this point, what I have been doing is, I look at their comorbidities. Okay, do you have asthma? Is this eosinophilic? I mean, at this point now, I look at their biopsy from their nasal polyps. Is it full of eos? And that kind of helps me decide which biologic I'm going to choose. And I'm going to be quite honest, usually I'm picking dupilumab. I mean, it works beautifully for nasal polyps. It works beautifully for the other comorbidities that they might have, such as asthma, such as atopic dermatitis. And so that usually is my go-to, especially if I know that it's eosinophilic-driven nasal polyps. I do occasionally have some patients who don't have high EOs, who don't have asthma, who are just really, really allergic, and they have nasal polyps. So that may be a situation where I pick omalizumab, Xolair. Their IgE levels might be super high, but their EOs aren't. But generally speaking, looking at the gamut of biologics that are currently FDA approved for nasal polyps, dupilumab is the go-to.
And I guess we skipped over this a little bit with Workup. So because I'm not usually getting a lot of labs for nasal polyp patients, but for you, are you drawing labs and looking at eosinophils and IgE levels? And is there anything else that you look for from a lab draw?
Usually I'm also ruling out immunodeficiency. So I'm usually getting a CBC with diff, looking at their EOs. I am getting immunoglobulins, so IgG with subclasses, IgA, IgM. I'm getting IgE levels, and I'm getting their response to pneumococcal vaccine to see if they can benefit from a vaccine booster. So that often can help with reducing their sinus infections if we give them a pneumovax or something of that sort. So that workup is very helpful going into biologic therapy, just to kind of pick your best biologic. But listen, let's say they come into me, they're ready to do something about their polyps, and I don't have that, I would still put them on a biologic.
So if you have a patient with a history, so what you're telling me is if you have a patient with a history of asthma, allergies, and maybe if they've been on, for example, Xolair and they've done well with an asthma, but now they have polyps that are uncontrolled, you wouldn't add the dupi to the Xolair. You would switch them completely because the dupi would also likely help both of those other comorbidities. People aren't on multiple biologics. You're changing.
Usually, or the dosing for nasal polyps with Xolair is higher than it is for usually asthma or hives or something like that. So I would maybe up the dose to see if that makes a difference first because they've done so well with the Xolair. And if that didn't work, then I'd probably completely switch them to something else. I mean, I do have some, pretty ill patients who are on dual biologics because they need both of them, one to control their polyps, one to control their asthma, and they have like this mixed picture. But generally speaking, yes, if it's not working to treat the comorbidities, then I'm switching to something else to see if it works better.
So then now moving on to talk about the newer biologic that's coming up, Tezepelumab. Let's call it Tezi. So this, I literally just yesterday was looking in one of our ENT Today, big 2-page spread talking about treating inflammation upstream. So unpack this a little bit more for us because we've got a new tool in our toolkit now.
Yes. Okay, so we're talking about, like you mentioned, Tezepelumab, otherwise known as Tezspire. We're calling it Tezi to be cute. And so currently Tezi is approved for severe persistent asthma in ages 12 and up. So I use Tezi quite often in asthma, a lot. And it's been an amazing addition to our biologic repertoire to have that option for asthma. So now I'm very excited about what we're seeing regarding nasal polyp data. So let's first talk about mechanism of action. So TSLP. TSLP is an inflammatory cytokine mediator that's typically released in response to epithelial barrier dysfunction. So if you think about it, you have your epithelium, the epithelium of your sinuses, the epithelium of your airways. And in response to certain triggers, whether that be viruses, whether that be smoke, allergens, bacteria, pollution, etc., your epithelial barrier gets shaky. It gets aggravated. And because of the aggravation of those triggers, it releases cytokines and alarmins, with TSLP being at the top of that cascade. So TSLP is an inflammatory mediator that gets released in response to epithelial barrier dysfunction. So when TSLP gets released, it causes downstream inflammation. So in the airways, that could be downstream inflammation leading to release of IgE, eosinophils, mast cells, basophils, causing airway hyperresponsiveness. In the sinuses, the same type of thing can happen where your epithelial barrier gets dysfunction happens, TSLP gets released, leading to downstream inflammation, causing release of similar cytokines that you would see in the airways, your eosinophils, your IgE, your mast cells releasing histamine, things that make your sinus cavities inflamed, which leads to the development of nasal polyps. So, long story short, what Tezepelumab is a TSLP monoclonal antibody. So it's a TSLP blocker. So it attaches to TSLP at the top of the cascade where the epithelium would release it, binds to it so that you prevent the downstream inflammation of release of all of these inflammatory cytokines.
Including like IL-4, 5, and...
Exactly. Your atopic/Th2 allergic cytokines. Exactly.
So TSLP is released first, and then with that mechanism, you get the IL-4, 5,
exactly.
13, all that stuff.
Yeah.
Okay, so if we're blocking
upstream, exactly. You're at the top of the inflammatory cascade with blocking TSLP. So then theoretically, if you're blocking it at the top, the downstream inflammation doesn't happen, and you don't get as much release of these other Th2 inflammatory mediators.
And you've been using it for asthma for a while. So how does it fall into your algorithm? Like, how do you choose that over the other biologics?
Great question. So Tezi's been around for asthma since 2020. And so we've had a few years trying to figure out what its role is. Definitely, I find that it works really well in my patients with severe asthma who often have an asthma COPD overlap, but it tends to be atopically driven, Th2 driven. So I definitely have my patients who are severe and maybe don't have their EOs may be a little high, their IgE may be a little high, but it's not like one versus the other that's super, super high. Typically, so as opposed to your other biologics for asthma, Tezzy, you don't actually need your biomarkers to qualify for it, meaning the studies have shown it doesn't matter what your IgE is, it doesn't matter if your EOs, what your EOs are, if you have severe persistent asthma, this is something that you can use. Now, as an allergist who loves cytokines and loves looking at these inflammatory meters, and most allergists probably agree, we like to know those biomarkers ahead of time because we want to best choose our biologic. But we find that in people who might not have both of those high, it can work as opposed to some of our other biologics, which may be better for just EOs or may be better for just IgE. However, the most recent data for Tezzy for asthma has shown that actually those patients who are allergic and eosinophilic, it actually works even better for them. And so, yes, you may not be allergic and eosinophilic, and it would work still pretty well. It has about a 70% reduction in asthma exacerbations for those patients. However, if you're allergic and you're eosinophilic, then you're going to have about a 90% reduction in asthma exacerbations with Tezepelumab.
Wow.
So it has a pretty big role. So reasons why I would pick Tezzy over maybe another biologic. I mean, I think about comorbidities because up until now, it's just been asthma. So if it's a patient who is eosinophilically driven, plus also has atopic derm, like I'm probably going to pick Dupi, But if it's a patient who has pretty severe asthma, who is biologically naive, hasn't tried anything else, and has low EOs, low IG, I'm going to pick Tezzy. Or both of those are high, but doesn't have all the other comorbidities, I might pick Tezzy. Also, Tezzy is 12 and up for asthma. So again, it depends on the age because I see pediatrics as well. So I mean, if it's a 6-year-old, I can't pick Tezzy for their asthma. So some of that goes into play, but I use it quite a bit for my asthma patients. I've had great responses, especially those who are like, I have some patients on oxygen, they're COPD, they're on oxygen, they're waiting lung transplant. But they've got EOs, they've got IgE, and I put them on Tezzy, and they do so much better.
And so have there been studies of Tezzy's effects on nasal polyps as well?
Yeah, so there is a phase 3 trial that was published in the New England Journal recently that came out, and I'm very excited about this data because it definitely gives us another option for nasal polyps. And so this was the Waypoint study where they looked at patients. Well, so I guess the idea came from they saw that these asthma patients, in the Tezzy studies for asthma, they saw that yes, asthma got better, but also as a sidebar, their nasal polyps got better. So which is why they came up with, okay, let's just now look at their nasal polyps. And so in this study, these patients had chronic rhinosinusitis with nasal polyps, and they had about 410 patients. So they had, a little bit over 200 in the Tezzy group and a little bit over 200 in the placebo group. And they put them on 210 milligrams of Tezepelumab, which is the same dose that we use for asthma, every 4 weeks for 52 weeks versus placebo. And what they were looking for was their primary endpoints was looking for changes from baseline in their total nasal polyp score, meaning the higher the score, the greater the severity, and their mean nasal congestion score at week 52. And then their secondary endpoints was looking at SNOT-22, looking at total score on sinonasal outcome test, and then the first decision to treat with nasal polyp surgery or use of systemic corticosteroids. And really what the study found is on all levels, primary and secondary endpoint, Tezzy led to a significant improvement in total nasal polyp score, mean nasal congestion score. These patients, their loss of smell got better, their time to get to surgery or need for oral corticosteroids reduced significantly. So overall, they found a huge improvement in the Tezzy patients in terms of their nasal polyps.
Were all of these patients, who had nasal polyps, did they also have asthma, or did they also include CRS nasal polyp patients without asthma in that polyp group?
So they didn't focus on the asthma. They could have had asthma. 60% did have asthma, but they didn't really look at asthma outcomes in this.
And were they not using anything else? Like, did they remove their nasal steroid sprays and anything else locally? Do you know?
Yeah, exactly. They continued their baseline standard of care treatment. Yes.
Got it.
And just kind of going back to the pathophys, we said it's an upstream cytokine and its role in type 2 inflammation. Because it's so upstream, does it have any role in type 1 or type 3? I mean, sometimes with type 3 inflammation, we might see some polyps, maybe less likely with type 1, but does the TSLP have any role in those?
That's a good question. I think yet to be determined. I mean, I wouldn't hesitate to start a patient on it for if they had type 1 or type 3 just to see. I don't know that we know that information yet. The hope is that because it is so upstream, you might get some improvements in your Th17 or your other sort of, Th1 type cytokines. But I don't know that we know that yet. I don't think that that's been looked at.
And sorry to jump around. Going back to the study, was it pretty safe? Were there side effects?
Great question. So yes, that's very safe. So they didn't find any additional safety concerns that they did in the patients with asthma. So there's no black box warning, no additional safety concerns. Your biggest side effects from Tezspire about, with a range of about 4 to 5% would be things like pharyngitis, headaches, kind of feeling like icky, things like that. Maybe some more upper respiratory infections. But again, 95% of patients really don't have any side effects. No increased risk of anaphylaxis or anything like that. So, I mean, in these patients that I prescribe for asthma, it's rare that I see these types of side effects. And so overall, we call it pretty safe. And in the nasal polyp group, just as safe as it was for asthma.
With those side effects, is that something they can expect to get better with time, or does it usually have to stop it? Or, like how long do you have a sore throat? Is it like, just a cup for a day or two after the injection, then you're better the rest of the month?
Great question. I mean, usually it gets better with time. I don't know that we know that there is like a time period, but usually they feel so much better in other aspects that they're just willing to continue because they can smell. So they're like, I'll deal with a sore throat if I can smell. I have had 2 patients stop because they did not like those side effects and went back to the previous biologic they were on. One was for pharyngitis. The sore throat was just miserable for her. And another one for headaches.
With the pharyngitis, visually, does it look like they're inflamed or they just have a chronic sore throat?
Chronic sore throat. No, nothing on exam.
With the other biologics like Dupi or Nepo, do you also get similar side effects? Or because I always just thought of skin irritation from the injection site, but
yeah, I mean, with any of these biologics, you can see any of those things. Certainly with Xolair, one thing we do sometimes see is joint pain, which is not really seen in Dupi. I've seen that in Dupi too with some joint pain. I haven't seen that with Tezi. Other than that, you're sort of like non-specific symptoms, sore throat, headache. I think with any of those biologics. And then like you mentioned, local injection site reactions are not uncommon, especially depending on, how it's administered and who does it.
Yeah. Are most patients doing it themselves at home? Do you get any pushback on people having needle phobia and, feeling like they need to come in and have somebody else do it or something like that?
Yeah, always getting pushback. Everybody wants to come into the office and do it because, especially your elderly patients, which, we take it as a case-by-case basis because, of course, insurance may not cover them to do it in office because it is meant to be done as a home injector. So I typically will have new starts, first injection, always done in office, just because you never know, and I want to train them and I want to make sure. I mean, maybe not everybody does it that way. I like to do it that way because at least I can show them. I know they're trained. I can watch them after their first injection for about 30 minutes just to make sure they tolerate it. We tend to encourage home administration just because it's safe to do it that way. But certainly there's patients who just will not, cannot, would not. And, they come into the office. It's once a month. It's every 4 weeks. So it's another thing to consider when I talk to a patient is frequency of injections because Dupi is every 2 weeks. Tezi is every 4 weeks. And so the question becomes is, if that is an important factor for them, less frequent injections, then Tezi may be a better choice. There's always the question about pain with administration too. Some injections and some biologics hurt more than others. And so Dupi is known to be painful. Patients cry, patients complain. The auto-injector hurts. Whereas less seen with Tezi, that pain with administration.
Yeah, I've heard when reps are kind of comparing the different biologics, I feel like that some of them have made that comment about if their pain profile is better than that being one reason to choose that over another.
Sure. Yeah, definitely. So is Tezi FDA approved for nasal polyps at this point?
Not yet, but my understanding is probably by the end of the year, especially after the meaningful things seen in this study. Hopefully by the end of this year, there will be an FDA approval for nasal polyps.
So you could prescribe it right now, but it probably wouldn't be as an off-label use, but it probably wouldn't be covered because of...
But if they had asthma, I'd just go down the asthma route,
Yeah. Speaking of cost, I guess, is it hard to get these medications approved for patients? I'm sure it depends on insurance and...
Yeah. I mean, it's a whole thing, you know. I mean, just biologic therapy in general. I mean, it's a game that you have to play with insurance. Honestly, that's why the ENTs send them to allergists, because they don't want to deal with the back and forth with insurance, the PAs. I mean, and I get it, because allergists, we do all the biologics and we see all the atopic conditions. So I'm happy to do the work for it because we know how to get it done, you know, like we do it so often, whereas some specialties don't do biologics as often. And so it's harder to get that approval. So, I mean, I think if you have really good staff, you have people who understand how to play the game and what they need to do. And then for the provider, like what verbiage you need to put in your notes to explain. Like typically for nasal polyps, they would have had to try and fail intranasal corticosteroids and plus minus sinus surgery. Some of the insurance companies are still saying they need to have at least had sinus surgery once to get approval. We're starting to get a little bit away from that. And now that is not always a reason to deny if they haven't had it. But generally speaking, I document certain things in the notes so that they can get that type of approval. And then it always requires a prior authorization. So that is always something that has to kind of do the back and forth. But I'm very lucky that I'm in private practice, so I get samples, which I think is very beneficial for patients because they're in your office. If you can give them a dose in your office to get them started and they start feeling better immediately, then that is something that can be helpful. That one, you know, because with the way Tezzy works is it works quickly. Within 2 weeks, people are going to start noticing a benefit. So even after that first shot, if they start feeling better, they're more likely to come back to continue the therapy. So I will try to keep them on sample until we figure out all the insurance stuff. But generally speaking, if you have someone good in your office who knows how to do the game and the hustle, it ends up being affordable for patients and it ends up being available for patients.
So for nasal polyps, it sounds like the two big ones at this point on your menu are going to be the Dupi and the Tezzy. Is that a reasonable statement?
Yeah, I think that's a reasonable statement. I tend to pick Dupi first unless they have some side effect. I have some patients who have had side effects from Dupi. You know, they may have had some kind of a reaction to it, and then I may go for Mepo or omalizumab. But now, once I have the option for Tezzy, I mean, that's going to be great because then I'll be able to pull that in.
And so your decision-making for that, would Tezzy, if it's a patient with severe asthma, you might choose Tezzy first. Or if the labs that you had mentioned, the EOs and IgE aren't as elevated, you might still choose Tezzy potentially first.
Definitely. I mean, I think there are no head-to-head trials looking at Tezzy versus Dupi versus Mepo versus omalizumab, to kind of see which one is best for nasal polyps. But from what I can tell, based on the data from this trial, Tezzy's way up there for nasal polyps. So, I mean, I think it's going to be a Tezzy-Dupi war at the end of the day, fight to the finish, see which one ends up. Love omalizumab, Xolair for hives, and it has its role, but for nasal polyps, it just doesn't hit the mark. And same thing with Mepo. I mean, again, I love it for asthma. It's got your hypereosinophilic syndromes that we use it for. But for polyps, I just don't find it to be superior to Dupi. And I think Tezzy's right up there with Dupi.
So I had a conversation with an allergist about allergic fungal sinusitis and potentially biologics for that. And, so like for us, like in my training, that is a surgical disease where we need to open up those sinuses and suction out all of that, peanut buttery fungal allergic mucin. And so the thought of just like it all kind of melting away with a biologic, I'm skeptical of that. Like, what are your thoughts?
I mean, I'm skeptical of that too. I think it's hard to truly break up that peanut butter. Peanut butter's thick. These are surgical candidates in my mind. And then I think of the surgery first, and then piggybacking that with, usually I use Dupi and allergen immunotherapy. Usually it's an allergic disease, so they're allergic to mold. And so immunotherapy, allergy shots there's a huge role for that. So I don't know that a biologic will just totally clean out all of that gunk. I do think these patients need sinus surgery.
And this might also sound subjective, but what do you consider as refractory nasal polyps? Like at what point? We know they're going to come back, but what puts them in the refractory camp for you?
I mean, I would say if they don't respond to steroids, right, that definitely tends to be like your more challenging nasal polyp patient, because if they don't respond to steroids, then you just wonder how they're going to respond to any of these, Th2 driven biologics. So I would call those patients refractory if they keep having sinus infections and things like that. I mean, those are patients where I start wondering if they have an immune deficiency. Like, what's up? Why aren't they clearing? Why is this such a persistent issue? And that's where sometimes we will find, an immune issue.
And you mentioned earlier that you may find more than one thing. So you may have patients who need infusions, but also need a biologic, and are also doing steroid rinses. And it's just,
Yeah, totally. That's often, that can happen for sure.
Anything else as it relates to access? Because I feel like one of the reasons why we don't have as much exposure to this in training is it's kind of, or when I was training, it was a very much like end of the road type of treatment. Like we have to try all of these things. And then if they're still not getting better, then that's when you might consider a biologic. But it seems like in your practice or in some allergy practices, it's not necessarily like, oh, we have to bang our head against the wall for 2 years before we consider doing this.
Yeah, the scope has changed. The scope has changed. As we've learned more, as we've gotten more safety information about these biologics. And again, allergists, we tend to be biologic heavy because we see how well they work in other atopic conditions, right? And so we're not shy. We're not scared of it. We found that these biologics are really safe. They're not immunosuppressive. They're not making patients sick. We're not seeing any big safety concerns. I mean, in some of these, we have indications all the way down to infants. So I think that our comfort with these biologics has expanded over the last few years. And I think seeing it used in real world data is super helpful. And so, I don't think of it end of line biologic. I mean, if a patient's coming into me and they're miserable, we are starting, like, it's first line in many, many ways for me. Get them relief, and it doesn't always have to be a surgical outcome if that's not the desire or the goal or the indication. And if they have like asthma and they have nasal polyps, I will sometimes put them on Dupi first and see how they do before they even have sinus surgery.
Do we know sort of long-term safety profiles and side effects? Like, so if you have patients, because now Dupi, has been FDA approved for 5 years, maybe at this point?
For nasal polyps, yes, but longer for asthma, right? And so
those patients that you've had on these biologics for 5 or more years out, 10 years out, do we know? Because I think that's another thing in the discussion that sometimes comes up. Well, we don't really know what happens super far down the line. And as a immunologist and, with that background, are there other things to consider once you've had patients on these for a long time?
I mean, not yet. For Dupi, it's FDA approved since 2017, but, we have years of studies prior to, So, I mean, if you're looking at having 15-year data on something, that's pretty good. Again, we don't have, and I always tell patients, we don't have 50-year data. So, I really can't speak for what's going to happen later. But in the 15 years that we've seen Dupi, in the 20 plus years we've seen omalizumab, I mean, we really haven't seen major additional safety concerns. Tezi, we have less information, of course. But, as far as I can tell, and from what the studies show, there is not necessarily an increased risk of malignancy, cardiac issues, more than no black box warning, no increased risk of anything for the years that we've been able to research it. So no, to your question, I don't have major safety questions or concerns as an immunologist if they've been on it for long term, at least not yet. Nothing enough to tell me to be worried.
When you're starting patients, is the expectation that they will be on it indefinitely?
I mean, that's always a conversation, right? There never is like this is what's going to happen, and then in 6 months you're cured. I mean, I make it very clear that this is a medication that is, preventing regrowth of your nasal polyps. And so if you stop it, could it come back? It could. And I kind of explain it like, if you have high blood pressure, then you have to take a high blood pressure medication. If you stop the blood pressure medication, your hypertension is going to come back. It's kind of a similar thought. Now, sometimes I will, like with Dupi, for example, if it's dosed at every 2 weeks, but they're doing really well after 6 months, I may increase that interval of how often they take it. So I kind of have them on the minimal amount that they need to prevent regrowth of their nasal polyps. So maybe that's at every 4 weeks. Maybe that's at every 6 weeks. We don't tell the insurance company we're doing that because then they're going to be like, oh, you don't really need it. I've had some patients successfully get off of a biologic. They just eventually wean themselves off and they're fine. And then I've had some patients where it all comes back. We just kind of have to do trial and error and play with it a little bit and see. And then if they're good off of it, then we just kind of see how it goes.
Does age, I just think of age, like when we're younger, our immune systems are more robust and reactive and responsive, and then with time it becomes less. Do you feel that, or do you see that with your patients who were maybe required it when they were younger, they're able to taper off or get off of it as their age advanced? Is that a thing?
Absolutely. Oh, that's definitely a thing. I definitely think, pediatric patients, they're resilient, man. Their immune systems are malleable. They outgrow things all the time. So I definitely do see that with kids outgrowing things and it not coming back and getting them off biologics more so than like your 70-year-old male, or female.
Which I think, knowing that as a parent, I think that would be, I don't want to say less scary, but you might be more likely to try a biologic if in your mind you could be like, oh, well, maybe this is not forever. Maybe we could just do this for a little while and then they'll outgrow it. And,
Yeah, that's a lot of, I do a lot of dupi for eczema. And they're these baby, these are 6-month-olds. They're little. And, I tell patients, I hope it's not forever. As their immune system gets stronger, their skin gets thicker, the hope is that we can get them off the biologic. But right now, nobody's sleeping. Everybody's miserable. Your kid is scratching every single night. Let's do something to improve quality of life now. What happens in the future, we will figure it out. So it's kind of a similar thought, I would say, with other atopic conditions as well.
Yeah. And it's nice to have options and people can make the decision that's right for them, right? And then future considerations, like do you see, for example, we were talking about Tezzy, now it's been working really well for your severe asthma, and now maybe we're talking about using it for nasal polyps. Where else do you see this going?
I'd love to see its role in atopic derm. That would be super cool if it helps with your skin as well, because theoretically, I would imagine it's the same type of Th2 inflammatory process. There's thoughts about looking at it for EoE, which is interesting. It's already there for COPD, so that's really nice. All the sort of conditions that I look at, it's nice to have options, to your point of what you just said. Right now, dupi has like 8 indications. Cool, awesome, I love dupi. But sometimes dupi is not for everyone. And so it's nice to be able to add some other biologics to, like Gopi said, our menu, and being able to pick the right one for your patient. And, a lot of times picking that right one may be based on frequency of dosage, pain with injection, side effect profile, et cetera, et cetera, et cetera. So I'm excited to see what it does for atopic derm and EoE. Those would be the 2 big things that I see that I'd be curious about.
Yeah. It's kind of like we have all these nasal steroids. Like we have all these varieties of nasal steroids, to talk to patients about. And some of them are like, oh, I don't like the taste of this one, or that one gives me a headache. So it's like, okay, well, we can try this one. And so it's kind of a similar thing.
Any tips or any insight you can provide on how we can cross-collaborate better with our allergy partners on these patients? What do you see has worked in your practice, and what do you find as roadblocks, or where you're like, man, this care could have been better?
Yeah, having that relationship between ENT and allergy is huge. I have my go-to ENT people that I can call, that I can text. They know that, like, also it's gotten to the point where if they send me a referral, I already know what it's about, and vice versa. So I think that collaboration is huge, right? I can't do sinus surgery. I can't scope. They're not going to do the biologic, and they're not going to put them on, typically not on allergen immunotherapy and things like that. So, I think that we all have our expertise, and to have that collaboration is huge. So I think having those few people in your back pocket that you can call, that you can text, that you can collaborate with is important. As an allergist, what I wish I could see more of in my ENT documentation is the grading of the nasal polyps. Because again, if they don't write the grade and the insurance requires that, but I'm the one doing the approval for the biologic, it's like going to be denied, So the grading of the nasal polyps is a big deal. Documentation of the nasal polyps, because when they do sinus surgery, documenting that piece of it. Sometimes we'll get the referral and it says Dupixent for nasal polyps, but there is no CT scan, there's no op report, there's nothing, So it's just sending everything to the allergist. What we need for approval is proof of the nasal polyps, grading of it, CT scan, surgery, and then that's very helpful.
Are you having to do like peer-to-peer conversations to get these approved?
I would say in the beginning, yes, because there was that whole thing of like, do they need sinus surgery? Do they not? It's anytime there's a new indication for something, it's going to be a little bit of a pain trying to figure it out. Now, no, I would say if they have documented nasal polyps, they've tried and failed intranasal steroids, plus minus sinus surgery, depending on the insurance, it's pretty easy.
And with the tried and failed nasal steroids, is it a particular type of nasal steroid that they want used, or a particular length of time, or okay?
Yeah, usually a month, and it depends on the insurance. Some will say Xhance, and then it's always a thing of like, well, how am I going to do Xhance if I can't get them approved for Xhance, So it is a little bit of that, some insurance companies, but for the most part, it is your choice of intranasal corticosteroid documented for at least a month.
Okay. Just one. You don't have to try multiple. You can just...
Usually. Again, insurance, it depends.
I know.
So I just recently got a denial because they needed to do Montelukast for a month. And I'm like, that's stupid. Like, that doesn't make any sense. But whatever. Prescribe the Montelukast. Yeah, I'll prescribe the Montelukast. I still have them on samples. Yeah, for nasal polyps. So I'm like, whatever, like it just depends on the insurance company.
Yeah. I've never found Montelukast to be helpful for nasal polyps.
Agreed. And now with its black box warning, everybody's scared of it.
Yeah, I don't even prescribe it anymore. I'm like,
I do sometimes.
For my reasons.
It's very
I don't have kids. I don't treat asthma, so I don't prescribe it. We used to, for mild OSA, consider a leukotriene inhibitor. You know what I mean? But with that black box warning, about 5-6 years ago, we kind of all started to, just do Flonase nightly and see how you do. You know what I mean?
Yeah. We've shied away from it a bit too, just because patients read about it. The actuality of the black box warning happening is so rare, and it works really well for allergic asthma, like no doubt. Like it still has its role, but because, people get so scared of it, it's not usually my first go-to by any means.
I know we're starting to wrap this up, but I have one last question. What percentage of your patients with nasal polyps don't respond to Dupi or the biologics? There's got to be a small percentage or a handful, no? And if they don't, do we have an idea why? Do we think Tezi, because it's more upstream, is going to be helpful? Or do we have to, and I know you'd mentioned there could be other etiologies like immune deficiencies, and that makes sense. Like, hey, maybe there's other workup, but in your practice, it's not always 100%. Nothing is.
Nothing. It is the minority that maybe don't respond. And then typically they're not allergic, right? You allergy test them and you don't find anything because, again, this is not a Th2 sort of process. I do think that there may be a role for Tezi. That's what I'm excited about, is maybe if it's upstream, it might work. If their polyps are, like you mentioned, grade 1, or if it's type 1, type 3, is it more Th1 driven? And then you start thinking about some other biologics that might be worth considering that is not in the Th2 world. That'll be interesting to see how that shakes out. So yes, it's the minority. It's not very often that they don't respond, but there are those patients, and I do think maybe Tezi might have a role for them.
For your non-responders, are we talking about like zero response, or they're just responding but not well enough that they feel better?
Again, it's minority, but I would say it's probably more the latter. They respond some, but just not fully, or they're still getting sinus infections, but maybe the polyps aren't there, or maybe the polyps are a little bit there, but their sinus infections have gotten better, things like that. But then, usually those are patients who are still doing their sinus rinses, and that can help some. And, so sometimes there is like multiple things happening.
As we wrap this up, anything that we haven't covered, anything to really drive home the point or leave our listeners with?
I don't think so. I'm excited to have another option. I think all allergists will agree that Tezi's been great for asthma. So having it as an option for nasal polyps is really amazing. So we'll just have to see. I'm waiting for that FDA approval. I think it's going to be big. The data is really good.
Thank you so much, Reena. I learned a ton. It was always wonderful to have you on and talk to you.
Yeah, thank you so much for having me.
If people want to reach out or learn more about you and your practice, what's the best way to do that?
Sure. You can email me anytime. It is Dr. Mehta, MEHTA, at uptownallergyasthma.com.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe Bagrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.